there's a few of us. Did anyone else get a notice that their trustee subscription had run out?
I did.
You did too? You did too?
Yep.
Yeah.
John, did your trustee subscription run out?
Yeah, there was a little thing in the magazine that said it
I
was
think
run
it's
out.
everyone.
So
Yeah, I think so.
Give me 1 second.
I figured Cliff was holding the check until.
So, did you get the message that, well, obviously Jim's not gonna be here.
Yes.
Okay.
Yeah. Yeah, and I saw that on the trustee had run out and figured, hey, they're holding the check.
I don't know what happened there. I see you guys have 7 board members, how many does it take to form a quorum?
We need 5.
We can do 4, and I guess we can appoint.
Four.
We need 5.
Even though there's only 7.
Oh, that's right.
I think it's out of how many there's supposed to be.
4 or 5. Yeah, we have 5.
Oh,
Yeah, we have 5.
good.
No, we have 4.
Ex officio.
That's right, Lori's ex officio.
Oh, Lori's.
That's right.
And
So
Tom
I guess
said
we
she
appoint her.
might call in.
Okay. That would be okay.
Yeah, you got that thing in the bylaws, right?
Yes,
CEO people.
yes.
Never seen
Or,
that.
Lori.
Oh, right, either one. Oh.
There you go.
Hi, how are you?
Hey, all right.
Yeah, hey.
Okay.
Well,
No, me.
Oh, I need a spoon.
I have an alibi.
Wandering around like a chicken.
Actually, you're in the front. You guys, 10 minutes.
Okay. Yeah, well,
Why don't I hang out and we'll do that.
yeah, sorry, that's absolutely.
Okay.
Yeah, no, understood. That makes sense. Let's do him first. And
We need a lot of signatures from you. In the annual program.
Oh, Dr.
Quit
Pfeffer.
sending us our
Yes, ma'am.
checks.
So medical staff report is up near the beginning, but then
Right.
I would guess.
And the
About what
the
time?
bylaw stuff.
Yeah, that's near the end though.
can't we go find
Yeah.
him afterwards and
Yeah.
get
Yeah, we
signatures?
can.
Yeah,
whatever you
we'll
wanna
come
do.
find you afterwards when we need you. Well, so we need,
So we're gonna be here
Approval
till
of-
7 o'clock.
no. We'll come find you.
You might be.
Might be here a little while.
Yeah, I won't be.
Those darn surveyors make students.
I actually still have a life. It's getting harder to tell, but
Well, we have to have something in place. I know they're not.
Right, and so we went through that Tuesday.
Right.
I signed it and Will signed it with a statement.
Okay.
John, put them.
Where, do we need
just
more
ask
than,
them.
he said that they signed them,
The bylaw,
yeah.
Med's down.
Oh, no, wait, that was Ned's thing.
The rules and
You mean
regs.
hospital,
The rules and regs.
you mean the Med staff rule and reg?
Right.
Oh, yeah.
Gotta have those signed.
If they're out of date, they're inappropriate for our facility. And we'll talk about it.
Okay, it will be,
let's move it up and get it done. Any discussion we have to have here, let's move up and
Okay.
get it done.
this,
So that we can get him out of here.
okay, we'll do that. What we need to do first, but, before we can establish a quorum, according to our bylaws, because we only have 4 here, 4 voting members here, we need 5 voting members.
Is Jim not coming?
Jim's not here. Jim Jim's not gonna be here today unless we have
Hit that-
Tanya on the phone.
That green phone button.
Green phone button.
Hello?
Hi, may I speak with Kirsten real quick, please?
This is she.
Hi, Kirsten, it's
Okay,
Penny.
wait,
Um,
You're on a speakerphone.
Oh,
Penny, we'll call you right back, thank you.
We'll call you right back.
okay, Kirsten.
We're expecting someone else. I could be mad. So, according to the bylaws, we, in cases where we need a quorum and we don't, ex officio board member, we can vote one ex officio board member on to establish a quorum. So,
Okay, I'll, move Lori Johnston, serve as ex officio board members for the day.
I'll second.
okay, all in favor?
Aye.
Okay, so Lori, today you are a voting board member, all right? So, it is 12:10, and, we'll do public comment first, and then we'll move on to the part where we need Dr. Hathaway. So, Mrs. G,
Hi.
did you have some?
I did.
Okay, go ahead.
I came here to address the board because I've had an ongoing issue with this hospital for a number of years. And
What's your name
my name is Diane Gingrich,
I'm sorry.
known as Mrs. G in St. Regis. Sorry.
She was my son's teacher, so.
And I've addressed this at a number of levels. I've spoken to different officers, and I know that things have changed over the years. But what I've noticed is that things have not gotten better. And when I received a phone call from the clinic from somebody checking on how things went, and when I told them the issues that I'm having, they suggested I come to the board. So that's why I'm here. This is kind of a complaint, but I believe that if you're gonna present a problem, you should offer some kind of solution also. So I'm hoping this is more of a discussion, and I don't know if that's allowed in this kind of meeting or not, but I have a
Would you like to become a member of the board?
I knew that was gonna be a question, and at this point, no. I'm working on managing my stress because of other health issues. So right now, I'm under care of a doctor that says I need to learn to manage my stress. So I'm not gonna increase that level because I know how this works. I have a couple of issues. One is about billing. One is about patient and family treatment. And one is maybe some options or something that I've experienced recently that might help you as you move ahead in dealing with these issues. I've had issues over the years with the way that our accounts are billed, and every time I come in and talk to somebody about it, I'm put off. I'm told, oh, well, this is changing, we're working on it. And I was in the hospital, I had services done at the hospital at the end of March. I had a colonoscopy, and I'm still waiting for a bill on that colonoscopy. Now, it should not take over 90 days for a bill to arrive. I've not been billed, my insurance company has not been billed, and I don't know how your paycheck works, but I'm a teacher and I get paid 9 months out of the year. So I scheduled this, had it done so that I could pay this while I was working, and I've not received a bill, and I'm off for the summer. I went into the hospital, asked about it, asked if I could receive my bill so I could pay it, and I was told that the hospital is not happy with the billing system, the computer system, something like that, and so the bills have not been let because of that issue. So my next question was, well, if it takes you 90 days or 120 days or however long it takes you to bill, do I have that long to pay it? Oh no, you have 30 days. Now, it's really difficult for me to see the equity in that. If you as a system cannot get your bills out within 30 days or 60 days even, because I understand sometimes you have something done and the billing cycle connects with it, but it's been 3 months and I've not seen anything, and neither has my insurance company. In contrast with that, I had to go to the emergency room at St. Pat's, and since then have been dealing with St. Pat's and with the Heart Institute, and last Tuesday, a week ago Tuesday, I had an angiogram, and I've already received the statement on that. I know already what it's going to cost me. I don't understand why that can happen here. I have 2 daughters that are accountants and billing, and when I said something to my daughter about not getting the bill yet, she said, how are they paying their bills if they're not getting their billing out? Now, as a taxpayer, in this community. I've always supported every time you've asked for money. But I'm starting to question, should I be giving you money when you are not getting money from the people that are using your facility? I have to question that. I have to ask, how efficient is this hospital in running? Also, when I do get a bill, I've asked to have it itemized several times so that I know what I'm paying for. If I don't know what I'm being billed for specifically, how do I know if I'm being billed honestly, and is my insurance company being billed honestly? And what I've been told was it's not cost effective for us to itemize our bills. I've received bills from several different medical institutions, and they've always been itemized. I know if I'm being billed for a CT scan, I know if I'm being billed for blood work, I know what I'm being billed for. That doesn't happen here. The only way we got an itemized bill, and I'm embarrassed to say this, was my husband came in his colorful language. I think in order to quiet him down, he received an itemized bill. That shouldn't have to happen. That's really uncomfortable for me to know that he has to do that. The other concern that I have is patient and family treatment. When I was in here for my colonoscopy was scheduled for 9:30, and I was told, things happen, it might be moved back. I understand that. But my husband and I came in because you can't come in without a driver.
Hang on just a minute.
Okay?
Tanya?
Yeah, I'm sending her to you now.
Okay, thanks. Hang on, we just got a board members coming in on
Okay,
the...
I understand.
Hello?
Tanya,
Yeah.
you're in.
You're on, okay. We're in the middle of hearing from a member of the public on a couple issues.
Yeah, Diana Gingrich.
Okay.
Okay, so go ahead and get.
Sorry.
That's all right. I came in for a colonoscopy scheduled at 9:30. We were here on time. I was called back. My husband was left in the waiting room. Things happen, I understand that, but he was not informed of what was going on. So I was back there waiting for my procedure. People were coming and going. People that came in after me came and went, and he still did not know. He finally had to come, search somebody down and say, what did you do with my wife? Because I had the procedure, I had some reaction to the medication, so it was taking a little bit longer, and nobody notified him what was happening. In contrast to that, I was in St. Pat's last week for my angiogram. He not only got to go with me to where I was waiting for the procedure, he got to stay with me the whole time. When they wheeled me off for the procedure, they told him how long it would take, when he needed to be back, and he was there when I came up. That seems to me to be a little bit more user-friendly and certainly more comfortable for the family. My husband was panicked when I had my colonoscopy because he sat there from 9:30 until after 1 o'clock without knowing what was going on for a procedure that was very simple, but there can always be complications. So I think that that's something that needs to be addressed also. I want to support this institute, and I know that there's been questions as to why the community's not using it and not supporting it. And I believe that if you don't know what the issues are, you can't address them. But I'm hoping that by coming to you and not just going, I've spoken to somebody named Ms. Blaylock at one point about these issues. I spoke to...
She doesn't work for the hospital.
Anymore. Oh, she doesn't work for the hospital?
She's the
Well-
health center.
Well, for a while, everything was connected.
Right.
And all the billing was connected. And I spoke...
That's not the case anymore.
I understand that. I'm just saying that I followed the procedures because I know about chain of command. I didn't go right to the top. I tried to go step by step. I spoke to Steve Carty, who I know is no longer here. I've spoken to several people. I've been to the hospital. I've been to the billing department. I know that Kirsten probably saw me in there one day when I was so upset because she asked us to move out of the hallway because they wouldn't take me back into an office to talk to me. I had to talk to them in the hallway. I want this fixed, and I want to be able to support this hospital, and I'd like to have a hospital here in our community. But unless things change, I don't know how that can happen. And I like my primary care physician. He's sitting here right now. I like the man. But I can't continue to do this and be treated so poorly. And I wanted you to know that.
Thank you, Diana.
Can we have, you know,
Let me ask you a question, Deb, prior to getting into the next gen conversion, about what was the timing on those going out?
5 days almost,
Okay.
you're close to 5 days. I'm Deb Green, I am the business office manager, I've been here a little while now, but we realize we do have issues at the front desk. I apologize for having you have to stand in a hallway and not being taken to an office. I would like to speak with you directly though.
Okay.
And figure out who you spoke with and what the issues are and what you're being told, because what I'm hearing is, raising my blood pressure.
And I don't wanna do that because I'm on
Yes.
medication for that too. But,
Um,
and I don't know the person's
But
name,
okay,
cause there wasn't a name tag.
okay, which,
I know you're working on that, I heard you talking about
yeah,
that.
so, as I said, we realize that there are issues in the front office. We have hired 2 new people now to address our public at the front. They are doing wonderful jobs, they're they're new to their positions, but we wanna make sure that they are addressing people correctly. I can put 2 and 2 together and probably figure out who you spoke with, pretty close. So, if we could meet or talk or make an appointment and have you come in, I would love to spend some time with you if that's possible.
And another thing you might wanna consider, just as a public relations idea, I have never seen this before, I was shocked. When I was in St. Pat's on Tuesday for my procedure, on Thursday when I went to get my mail, there was a thank you card from the staff, personally signed by the people that worked with me, the guy that rolled me from where I was waiting down to the procedure room and back, and the nurses that worked there. It was very touching, and I know it doesn't cost a lot to do something that little, but a phone call, a card, something to let people know you appreciate and value and check to see how they are is really nice.
We are starting a callback phone.
You didn't get a call from Monty, or?
I did get a call from Monty,
Okay,
which
so
is why
that's
I'm
our
here.
version of doing that.
Yeah, but that was on my visit to Dr. Pafford, it wasn't on my visit to the
Monty's
hospital.
just getting started in the
Yeah,
hospital.
and we're just getting that
Right.
started going, so.
But
On the
that goes a
hospital side.
long way,
Yeah.
it goes a long way.
And you're right, unless you say something, how do we know?
Right,
Right.
exactly.
I appreciate that you've come.
Amy,
You're right, we wanna get the bills out too.
May I address?
Go ahead,
This is
Kirsten.
G also.
Yes, go
This is G, we know each other, I'm Kirsten Locke, I'm
I
the
know.
Director of Nursing Services, and I'm also the surgery supervisor.
Mhm.
And so I'd like to start by apologizing for what happened to you and your husband on the day that you had your colonoscopy.
Mhm.
It's important that my team recognize that there are areas where we need to improve, and I'm talking about the surgery team. And so I'm also the person in our facility that handles all customer feedback of a clinical nature.
Okay,
And that's what you're talking about when you're
Okay.
talking about your husband not being informed about your progress during the procedure. And so I would handle that as well, and so I'd like to talk to you, I'd like to find out which members of my staff need some training in that way, and what happened that day, and how we can improve and make it better for the next person.
absolutely. But how do we know who we're supposed to, I mean, I think that's a public relations
I
thing
think-
that you
I
need to
think-
get out there.
Yeah, and I think that's one of the things that, my staff should be recognizing is that we need to get people back to me and answering questions and not giving these blank. So, yeah, we definitely need to do better. And we're on that trail, but we do have a ways to go.
It sounds like to me, I didn't do very good training when it comes to the part about when a customer comes to you with feedback, what do you do? Because we have a process, and we realize that customers are maybe not comfortable coming to me, but they might know somebody at the hospital that
Right.
they'd be comfortable sharing their bad experience with. And so the response is supposed to be, you're right, I don't work in surgery, but I know what to do.
Exactly.
And I'd like to take your name and telephone number and give it to someone who will call you back and get more information. And so I didn't do a good job training whoever the person was that you spoke to.
Well, I didn't speak to anybody about the colonoscopy,
Oh, okay.
and I didn't know about the way my husband was treated until later. He didn't want me to know, so.
just to comment on that, I've had 3 colonoscopies, and none of them here, but one in Malta and 2 in, I'm getting to be an old guy. I have to have those every once in a while, you know. And my wife also has had a couple 3, and I've never had the experience of, like you did, you know, you kind of made the analogy between, you know, St. Pat's and here, that your husband was able to go into the procedure, but with a...
No, not into the procedure, but into the room where you waited for the procedure, after they prep you?
Oh,
Yeah.
sure. Yeah, my wife did that.
Yeah.
But, I thought you meant clear into the procedure.
Oh, no.
No.
Oh, no, we're not that close.
Didn't know that part. And also, ma'am, we have a patient satisfaction committee, a separate little subcommittee. I am on that committee, and I'm encouraging people, if they don't, because I'm not connected to the hospital or the clinic at all. I'm just somebody who got into this job. But I'm really encouraging people to call me if they don't want to necessarily talk to somebody that's employed at the hospital. And we've got a patient satisfaction committee, and I bring those things to that committee meeting as well, and they get discussed, and then they have people contact you who can help you.
And I think that's all wonderful that it's out there, but what's sad is that the community doesn't know it's there. I mean, I didn't know that there was this.
Yeah.
I didn't know, I mean, how do you know?
That's right.
So that would be another thing that I would suggest that we work on, is getting that information out to the public.
Yeah.
You can't improve your image if you don't let people know what it is you're doing.
That's true.
Well, and we already have big fat ads in the newspaper. I don't know why we couldn't just add some of that information.
We're putting that bulletin board down at Castle, we could put that information right on that bulletin board.
And maybe in a bulletin board in the post office
In
in
St.
St. Regis,
Yeah, we're thinking of-
or in the West End, because there's people throughout this community that, you know, that you want to support you, and I would love to if I felt welcomed and respected.
Thank you for coming.
Well, we want you to feel...
I think it's important. I think, I believe that we need to solve these problems, not run away from them. I've never been one to run away from problem. I confront them head on, as you probably know. I'm pretty straightforward, and I'm not angry. I'm trying to be helpful here. I just want you to know what my experience was, what it's been over a long period of time, and I know there's been changes, and I know that some of the people I've spoken to aren't here anymore, and for some of that I'm glad, but we need to know what's happening here so we know where to go when we have an issue. When we can say, thank you, you did it right, and when we can say, wait a minute, we need to do better.
Sure.
Because I'd like to be able to do both sides of that, not just complain. So that's why I'm here.
Thank you for coming.
Yeah, thank you for
I
coming.
can kind of comment on a billing issue though out of St. Pat's. I just received a bill from my mother of a procedure that was done a year ago. And I just got it.
Yeah.
In the meantime, she's passed.
Right.
So
That's hard.
I just kind of called and said, you know,
Too bad.
it's been a year.
Yep. And I've had that same experience. I had that same experience years ago with my father-in-law, but I want to help. I want this clinic, I don't want this clinic and this hospital to close because we lost our one in St. Regis. I don't want to have to go to Missoula. But if I have to be treated respectfully and carefully, I will.
Yeah, you know, Monty's name was mentioned, and, you
He's
know, I could
wonderful, by the way.
pretty close touch with Monty on this new project of him calling back. He's just starting that, you know, on the hospital side. He's been doing it on the clinic side for quite a while. But both on the hospital, you know, he talks to a lot of people who have both services. I mean, you know, as you kind of indicated, I mean, most people think we're still one anyway, but.
Well, I got in trouble on billing for that one, so now I know you're separate.
Right, and even though we aren't, but you know, the high level, I've been here 8 months, and during the town hall meetings, you know, Bill and Kim Manch and Cindy Sturgar and I went around the county. We've been in all of the communities, including DeBorgia and St. Regis, you know, 3 times in the last 8 months. And each time, the dull roar, you know, the decibel level on billing issues for both of us, you know, for both of us, has been much reduced. You know, Monty indicates that he just doesn't hear nearly the feedback that we did, 8 months ago, 7, 8 months ago, when we started this process, the town hall meetings on billing. So I think it's getting better. We do still have these cases that we need to work on, absolutely.
Have you got the computer system that you like now, so I'm gonna get a bill in a reasonable amount of
It's not a
time?
matter of liking a system or not. We had to go to an electronic health record. Every electronic health record has issues. What we're doing from the billing end is we are making sure that we're going through every account. Since we went on to the next gen system, we're making sure that the documentation is there, and we're making sure that the charges are in correctly, and that takes us some time. On top of that, surgery and scopes are a lot more difficult than just a simple lab bill. And so the coding is fairly new to us. Dr. Gardner is very new to us. So we're working through some of those pieces and parts. Surgery is way slowed down. I haven't gotten any surgery claims out the door since March. We are trying to get the bulk of most everything out the door. The simpler stuff that we can make sure is there. So we are starting to receive, there are claims going out the door, we're receiving payments. As I was telling John a few minutes ago, we are actually seeing payments from insurance companies and billing secondaries as of the last couple of days. So things are starting to come in. We had a 45-day period, 60-day period where no claims went out of the system.
And
So-
your bill got caught up.
And your bill is one of those. I mean, surgery.
I understand those
And I
things
won't
can
talk
happen.
details,
Yeah.
but your bill previous to your surgery was out and
It was,
taken care
and
of
already
very
got
quickly.
it paid, and that's, because that's what was so confusing me, because I came in for blood work and a EKG before the procedure, and I got the bill on that, and
And that was seconds before next gen.
Yeah,
so that went in and went out, and then nothing on the others, and somebody said, oh, well, your insurance pays for that, so that's probably why you didn't see it. Well, I still get a statement from my insurance company, so that I can double check it to make sure it's right too, and I'm not seeing any of that, and that just is like very disconcerting.
So there's,
I got the bill from when I went and signed in afterwards.
I'm the CFO, and I can guarantee you that you want the bills out only half as much as I do.
Well, but as a taxpayer, knowing that I'm financially supporting this facility too, I want to know that you're doing everything you can to collect those bills.
You're the only one that didn't get a bill. We're getting it.
I'm sure that's the case. And I know that's not true because I've talked to other people,
Yeah, that's
so,
not true. Okay,
Thank you for
thank you,
listening.
Diane. Okay, let's move on. Let's do meeting minutes while we were waiting for Mr. Bafford. So, did everyone have a chance to review our last meeting minutes? I actually had something I wanted to clarify on there. On page 8, where it says the health center board agreed to let the $36,000 go and pay the full $43,000 if the debt was forgiven by MCH. I just wanna explain that a little bit better, what that even meant. And it wasn't 140, it was 146,000. But just, the health center board agreed to let the 36,000 of the credit card money to, go to MCH and pay the full 146,000 for innovations, if the debt was forgiven.
so 143 should be 146?
Yeah, I didn't see a 143 anywhere. And I'm assuming that's what that was, because that sounded like the conversation that we had.
Yep.
Did anybody else?
Does Mitzi have the right
146?
words here?
You paid the innovations, or that was the
I
one?
think so, 146,417 or something like that.
Yeah.
was exact.
Yeah, we spoke in round numbers when we discussed it here as a board, but,
Are you okay with
The
it?
$36,000
That's where
credit card.
Cliff, that's where the 73 half
Right.
came in.
Right.
Or you could even say to let the 36,000 go to MCH, but just to say to let the 36,000 go doesn't make any sense. Just so we're clear on what that was for.
Okay, and 146, from innovation or to?
To innovation.
Was, yes. It was it was paid by Regional Health Center for
Yes.
innovation.
Yes.
This is Patrick.
Were there any other changes that anyone
I
had?
had no other changes.
Tell me what he's there for.
This was about as difficult minutes as we've had since I've been on the board. I was amazed she did as
They're
good
really
a job
detailed,
as she
they are
did.
very detailed.
Yep.
So,
Okay, I'll move with those corrections that they be approved.
I thank you, John.
And I'll second it.
Okay, all in favor of approving board minutes?
Aye.
Any opposed? Are you voting, Lauren?
Yeah, I should have.
Oh, okay, thanks. Okay, moving on. We will come back to that staff report. Let's go to the CEO report.
I really don't have anything, I put the report, unless you have questions, I put it in the packet to try to save some time today, because I knew we'd need it.
Okay.
Any questions,
Is that September 30th date hard and fast?
Well, I told you the other day, I've been here a year if I stay another month, so I think beyond that, it might get a little dicey with your spouse, but, especially if we've identified a CEO candidate, and, we need to transition.
Yes, there's a start date on the 12th, he'll be fine. If there's a, yeah.
Yeah.
We do have another option, and I guess we've discussed this in a couple committee meetings and things, but several of us attended a critical access hospital summit that St. Pat's held last week. Larry and I and Gary and Jim were there, and St. Pat's indicated that if something came along that we needed, they would be willing to supply us with someone who could serve as an interim CEO if we got to September 30th and didn't have the right candidate in sight yet. They're doing that now in Phillipsburg. It's not something new for them, and from what I'm hearing, that's working out reasonably well. And Phillipsburg is certainly having lots of issues to deal with over there right now. So we're not without an option, and I think that's good. As a member of the recruiting committee, we are bound and determined that we need to make absolutely certain, and of course the whole board will be involved, and the leadership team involved in making the decision, but we're bound and determined that we don't want to settle for somebody for this position. It has to be somebody that's really right. It's extremely important to the future of this hospital that we get this hire right. Rather than, even if that September date is firm, it's not going to be a gun to our head because we've got another option to keep going on a temporary basis to make sure we get the right person to fill the job permanently.
Okay, and if there's more on that, we do have an item on that.
Yep.
Okay, let's move to our, thank you, Larry.
Sure.
That's the shortest CEO report we've had. Medical staff report, Dr. Copper?
Yeah, sure. So, first of all, you guys had some signatures. Do you want to talk about those now?
Well, I think that we need
Down under
to,
the record survey and plan corrections.
yeah. Is that, did you have
You
anything?
wanna do that?
Yeah, I think that we'll wanna move that while we have Dr.
Yeah,
Copper
sure.
in here. Do you have anything besides that,
Besides what?
besides the medical records and staff rules and regulations, besides the signature issue, was there
The survey,
anything else?
Plan corrections.
Yeah.
Anything
That
besides
the med
that?
staff would like to report to the board?
I'm not sure what your question is. Could you rephrase that so that I can
So-
answer it?
Do you have anything else to report?
Do you have anything else to report?
Okay.
We'll get to
well,
that in a
okay.
minute.
What I'll tell you is, so for those who don't know and need to know and would like to know, So we had a surveyor come and look over our bylaws. I don't know if she looked at rules and regulations, and then looking back at that, they looked to see how long it takes providers to sign off. I think that's considered a completed file. And then you look back and you say, oh wow, look at this chart took 103 days, or this chart took 21 days, or whatever. And so our attention's been turned to, well, let's fix it. They made very specific recommendations. Larry has a complete list of all that stuff. And a couple of the things are coming up with a rule for the providers so that we have a way of dealing with signatures, completion of charts, as far as the provider's contribution to that process. There was, in the old days, apparently it said if a chart wasn't finished in 15 days, fire the provider. Okay, whoever wrote that, I'm sure they never did that, whoever wrote those old bylaws.
Is that still in there?
Well, okay, that gets us to the other question, which is, I don't want to get ahead just yet, but, so, because Larry did ask last week, questions about bylaws and rules and regulations. And, because we have a deadline ahead of us, June 30th.
Right.
There's some things that gotta get done.
Right.
And I know that, and he made that clear, and I also made it clear that there's some things that we can and can't do. Okay. And in fact, there's some things we won't do. Okay. So
Sure.
having said that, that's been our problem, perhaps in the past, is people just wanna, here, sign this. Really? You didn't fix anything. So anyway, we're getting ahead of ourselves. So anyway, yes, as part of our rules and regulations, we'll have a plan whereby if a provider doesn't finish a chart, say in 15 days, that a notification goes out. And in the meantime, keep in mind, medical records can send out weekly reports saying, hey, look, you got so many charts that need to be completed. And they'll help keep track of that 15 days. Then with them receiving notification, my plan will be to suggest that then you have another 15 days to respond to that. And if you don't respond, you get a 5-day notice. And after that, a hammer of some sort will fall. Some sort of.
I'll withhold their travel check.
Just something that, something that
Is an incentive to.
is not unreasonable. Come on, do your job, finish your charts, please. I mean, if the medical records has done their part, all the pieces are in place, why shouldn't I be able to come around within a week or so and, hey, let's finish this off, okay? Because there's always somebody who gets held up somewhere along the way, down the road if we don't, and that's how all that started. So, we have a solution there, and I think that's an equitable solution. Now, the specific nature of that hammer, we have not worked out, but Larry and I did speak briefly, and in fact, we spent an hour talking about it one day. It'll be important at the end of that 5-day period of time for either your medical officer or your chief of staff, I should say, not the medical officer, but the chief of staff. Wrong function. Chief of staff and the CEO to sit down and say, how do you want to proceed with this? Because obviously.
Well, and Dr. Pavitt, I would think you would agree that, certainly that we've, we're starting to meet with the sandwiches, every Thursday, and, that I kind of wrote that into the corrective action plan, that you and I would discuss, the bad actors that have completed their charts, and we would both, you would go ahead and visit with those, and we would review those lists.
Yeah,
on an
and
ongoing basis,
so.
every Thursday, so.
So that's good, that's a good thing, and not only that, I've already spoken to a couple of providers. I kind of like letting providers know
Yeah, that's
what's
really
happening,
good.
because it's real important. What you're ultimately talking about is, you're talking about not just a rule and regulation that's supposed to be sort of spelled out in the med staff rules and regulations, and then of course there's supposed to be some sort of instrument up here in the bylaws, which is a contract between the med staff and the hospital that says we're going to be timely about finishing things, because
Right.
we don't want to hold it up. But anyway, the bottom line is, the whole purpose of rules and regulations is to make it so providers can do their job, but also so you have due process. Actually, that's the purpose of the bylaws. But again, rules and regulations, which specifically is supposed to regulate patient care, well, this is a patient care issue. It's also a bylaw issue. So anyway, we've talked about it. I'll formalize that. Larry and I'd hope to have the rules and regulations done earlier this week, but our rules and regulations are so antiquated. I mean, you cannot believe that about 1/3 of the material should be gone. So again, without getting ahead to another topic, I'm at the point now where I can put together a line of some key elements that should be in there, because I've looked at 3 or 4 sets of bylaws, 2 sets of rules and regulations, and you sort of get a flavor and a hint of where all this is going nowadays, and what material should be taken out of our rules and regulations, because we just have stuff that's doesn't apply in any fashion. Now, we have a June 30 deadline coming up.
I was gonna say, how large of a document is it?
You're talking about.
I mean, I know the med staff bylaws are like 80
No,
pages.
bylaws,
They're so,
Hold
they're
it,
pretty long.
you get way ahead of me. We're not talking about changing the bylaws.
How long
bylaw-
are the rule and regulations?
About 6 to 8 pages.
Okay.
Okay. So, another day or so, fine, we can get that together for you, at least somehow reflect what we really do here. What I don't want to be is one of these people that's gonna sign off on another garbage document that doesn't even reflect what this hospital or facility or med staff needs, and we just propagate the same old issues and problems we've had in the past. And I refuse to be part of that process. Give me a couple of days. I've already talked to enough providers. Because you have to understand, the rules and regulations are, it's not just someone lording over the other providers, which is how the previous ones were written. It has to reflect how providers really anticipate they want to practice. So that means, yes, I've spoken to Dr. McClellan. Yes, I've spoken with some of the primaries. I need to speak with Dr. Gardner, because he should have a say.
Sure.
And when we sit in there, now, some parts are simple. We have outside reviewers who review our notes and say, hey, we're consistently, if this is missing, we would like to start seeing this in notes. Fine, rules and regulations, these are the elements of an H&P. You can say that. These are the elements of a discharge summary. Get everybody on the same page. So anyway,
Can we get it done?
we can get
By Monday,
Can-
6:30.
Well, I mean, can we
Yes.
get it done? That's.
yes, the answer is yes. And I've put some time into it, I'm not goofing off on this. That I need a few more conversations with people,
Sure.
because the goal isn't to humiliate or alienate providers, the goal is to include them.
Right.
Okay. So the key things in our framework, we can at least get rid of the garbage that doesn't belong in this document, that doesn't apply to us. And we can include new language that reflects what? Our EHR. And some key, simple, basic points about making sure you put in a billing fee for your work, or making sure your notes are done within so many hours, okay? We don't have any language that reflects that. It does say all of our orders should be in writing. Should I keep that in there? I mean, that's antiquated. It doesn't apply, and regarding C-sections, But in theory, Dr. Gardner can do emergency C-sections, so maybe I should talk to him and say, hey, is there anything you want in here? But we're not trying to specify all the nuts and bolts, but we do need to rip out the shape, and that's fine. I've seen enough examples of how other people are doing it, and I took ours, cleaned it back up, put it through OCR so that it's an editable document. And now I can go back through and just start inserting things, and I can start sending to people and say, hey, I need you to look at this tonight. So that's good.
Yeah.
That's good.
Thank
And we
you for
can
putting so
include,
much time
we can
into it.
include
Yep.
new issues that have come up over the past 12 to 16 weeks. And just make it a matter of, here's the rules and regulations. So,
Can we just sort of agree to do it this way then, that, if we'll try and have it completely done by Monday, so we meet the deadline.
It's gotta be.
Well, here's where I'm going with that.
that's my question.
Well-
Because I really want Larry to have a chance to look at it too. I mean, I can send it to him by email, but I know it's a Metastaff document, but I want him a chance to be able to chime in.
Sure. Well, and here's what I'm gonna suggest with that. Let's try and get it completely done with all the changes the way you want it by Monday. To the extent we're not completely there by Monday, can we agree, we'll sign what we've got
Sign what we've got.
with
because
the
I'll rip out
agreement
the
that
shape.
the board will help both sides stay on top of completing the process of changing it after Monday if it's not completely where it needs to be by then.
John, that's exactly what I proposed at the medical staff meeting last month. And after much discussion with Dr. Pafford. He agreed with that, with
Okay.
the medical staff bylaws, the longer document. And he, I've got his signature on that.
Okay.
He and I both signed that,
So
which we
we're-
have to do.
And-
But the rules and regs, we don't have that. And, I don't like this process any more than Dr. Pafford does. It's kind of rushed, and it's all because of the survey.
Right, no, I understand, and that's why I'm looking at a solution.
If we did
that
the right
meets the
job.
deadline, but solves your concern of making sure it's ultimately done right.
Well, it'll be done, you know what, I think we'll get to 90% and that's fine.
Okay.
The other part of it is, for those who don't know, the bylaws are an entirely different issue. The bylaws that we have were written in 2006, and for those who don't know, bylaws are actually written with the intention that they won't be revised frequently. They're intended to be a foundation set of rules that you can go on for 5, 6, 8, 10 years. And I don't know if there's a standard out there how often you should review them, but we do have a 2006 set of bylaws. You need to know ahead of time that the bylaws and regulations will not coincide.
Right.
There will be things in those rules and regulations which you can repair frequently if the bylaws so state. And I don't remember that comment, so I'd have to go back and look at it. But bylaws aren't that way. In our bylaws, if we're intending to do a genuine, real review of those, and perhaps it's time, it's been 8 years since the 2006 bylaws, that is a lengthy legal process.
Well, yeah, it's not only has it been 8 years, we are a different place than what this place was 8 years ago.
That's true.
That's true.
So,
Okay, so, yes, I'm hoping to have everything I need from people, talking to people, and have it just right there by Saturday or Sunday. Okay, I'd hoped to have it done sooner. That was naive, because there's more to it than that.
it's always harder than it looks to me.
Yeah,
The rules and regulations, I'm assuming that's something the board needs to sign as well.
right.
Totally.
So
That's why I
what,
put it on.
And
Well-
what I can do is, I mean,
We
I
could
can
have
call
you
you.
sign though right now the bylaws.
I was gonna say
I've
is,
got the bylaws here.
yeah, I was gonna say one thing that we can do is we can do a motion with this, with the stipulation or that, that the executive committee is given the authority to do that on behalf of the board as well. There's a couple of different ways we can do that.
and my statement that I wrote on the bylaws Tuesday of last week only says that these are the bylaws under which we are currently operating, and that revision of these bylaws should be anticipated within the next 6 to 12 months.
Yeah, I see that.
Laurel in turn signed beneath me stating she concurred with my statement.
Right.
Yeah,
We're
I
not
see that.
saying we think the bylaws are right. We're not saying we think they're right for us. I think we do need to revise them.
Well, I think you're right.
Okay,
Yeah, no, and I see that.
okay.
I think you're
I
right. We're
agree
not
with
gonna
that.
get that done by Monday, but we need
No,
to
and I
get-
agree with that as
yeah.
well.
Yeah.
You might need a motion right here to,
We do.
to allow.
Does the whole board have to sign the rules and regulations?
No.
or certain-
No, just the chairperson?
Just the
Oh,
Yeah, but the board has to approve it.
okay.
And if I can run on just one more second.
Go for it.
My hope and goals would be, these are med staff bylaws, for those who do not know. They only apply to the medical staff. The reason for that is it's a contract between all providers and a hospital. That's not the same thing as hospital bylaws. And my hope would be that eventually we would revise all those so that the bylaws and the rules and regulations coincide. They agree with it. There's no
Yeah.
contradiction.
You'll be changing them again.
Okay.
Amy, I have a question about that. What's the governing board's plan to enforce those bylaws once you sign off on them today? Because there are requirements in those bylaws that affect some of the work that I do. And for example, the medical director's participation on certain committees, members of the medical staff being required to show up for their medical staff meetings where important information is relayed. And so what's the governing board going to do to enforce the bylaws and to make sure that they're followed?
The med staff bylaw?
Well,
Go ahead.
Yeah, cause that was part of our deficiency, was that the governing board was not seeing to it that the bylaws were enforced.
I think the deficiency related more to the fact that that the governing board, was very specific. I mean, all the tags that were cited were on medical records issues, and, there was no, you're right, there was no oversight by the board to make sure that, that those medical record deficiencies, but, and, it's very specific that all it says is that, you need a signed copy of the bylaws and the rules and regs. That's gonna satisfy the resurvey.
Okay, go ahead, Dr.
well, I was just gonna say, I understand the teeth question, Kirsten. So what's supposed to happen is this is where you have, this is why you have a CMO. CMO's job is supposed to, your med staff over here is supposed to say, wow, we have these deficiencies here, our providers aren't following the rules and regulations, they're not obeying the bylaws. And at that point, your CMO's job is to notify your governing board. Now, that's what I've gathered recently, to say, hey, guys, this isn't happening, we're working on it, or whatever. They're actually go back and forth both ways. Your CMO is supposed to be an independent person.
Well, in
Of
theory,
either
that's
body.
all well and good, but when you're a financially struggling hospital, there is no way in God's green earth that this facility can employ a part-time, full-time, half-time, tenth of a time CMO in addition to the chief of staff.
Well, I understand.
Never, ever seen
And
it.
that wasn't my point, Larry. I wasn't saying, that wasn't my point. I understand that. No, my point is understanding the function of that person, because the question was, where are the teeth?
Right,
Where are the teeth?
right.
I'm sorry, but what is a CMO?
Aha. A chief medical officer is not the same thing as a chief of staff or a president of staff.
Oh,
A chief medical officer has other duties. The basic duty is communicating between the medical staff and the governing board, and going back and forth.
thank
You
you.
can have a chief medical officer who is also a member of the staff, and staffs write in rules and regulations. Can you vote once? Can you vote twice? What are the rules? You write them out and you follow your rules. That's the simple version. You make up rules and you follow them.
Great
That's
idea.
what you do. And then if providers don't do their job according to the med staff bylaws and the rules and regulations, then you follow through with all the little steps you delineated and set forth in those documents.
And I think, Amy, that's one of the processes, that this board has had is when I came on, we had never had a provider that
Even showed up.
Well,
even
right.
showed up, and so I
It's
think
defining the rule.
getting that communication between the medical staff and having somebody come and report to the board, that should be part of probably
that was-
the process of what
In
happens.
33 years, 34 years, I've never, hanging around hospitals, I have never seen a situation where the chief of staff didn't come to the board meetings.
So it's great we have
Absolutely,
documentation.
yeah, absolutely.
Sir?
There's an issue that's been haunting me for about 3 or 4 months, and it's regarding getting your request for medical director training, some kind of a program, because you're giving all these responsibilities and writing all these documents, and a lot of your time's taken up in this administrative function. And still, last time we spoke, you were going to kind of look into it. I don't know how far you got with that.
I told you I'd get a solution that day, and I had one.
Good,
Okay?
good. What do we
It was
need to do?
easy. It takes all of 30 minutes to answer that one.
What do we need to do?
The American College of Executive Physicians has programs, you pay them a yearly fee, like $300, and then they've got all sorts of coursework. And that frankly, you can go out as far as, you can just do it to do it and say you've done it. Some people go so far as there's 4 universities behind it, so that if you actually wanted to go so far as actually getting degree credit for it, you can get it. So it's all right there, American College of Executive Physicians. And they seem to have it all thought out.
Is that something that's satisfactory for you to do, like online?
I think, yeah, you can do it all online, or you can do the various things. It might cost a little money, I don't think it's horribly expensive. We're not talking about paying for someone's college degree here. But it's gonna require a few dollars, and, yeah, I would love to get started on that, because they have everything.
What do we need to do in order to make this happen? Because,
I just need to know what a credit card is.
okay, so do we need a motion on the table that somehow we get, the training requirements that
I
are
think
needed?
they can get started on, they even have pathways, like, you should know this, and you should know this, and you should be doing this.
Yeah,
I'll make the motion that we approve the training.
Okay.
a second.
Okay. All in favor?
Aye.
Aye. We're missing.
Aye.
Oh, Tanya,
Tanya,
we're good.
Tanya's there. Yeah.
Go do it.
thank you.
Go do it.
Motion for you to sign the rules and regs and stuff.
Oh yeah, we need, well, let's start with this one. Then I'll get back to
Bylaws
your
first.
question. I know we
Medical
didn't
staff.
answer your question first. This right here is the bylaws. We do have all of the signatures, with the note that Dr. Pepper described is on here, but we do need an approval of the board to do that. Tanya, can you even hear us?
Yeah, I've been able to hear everything so far.
Okay.
It's so pretty sensitive.
So I'd entertain a motion to, for the board to be able to sign off on the hospital med staff bylaws.
I'll make that motion with the understanding we are gonna go back and look at them.
Well, med staff will do that.
I'll second that.
Thank you, Lori. All in favor?
Aye.
Any opposed? So what do I sign? How come we don't have a non-signed one?
Well, this is just the 2006 version.
Yeah.
You know, basically, Roger and all of us have just acknowledged the 2006 bylaws until we get them rewritten in 6 to 12 months. I won't be here though, so.
Up to you.
Okay, that one's signed.
Well, maybe I will.
I'm assuming, Kirsten, you were looking at what they said on here?
Well,
How
and
it
when
said-
Larry had to write his plan of correction, and we don't have that right now, but there was a piece of the plan of correction where it said, and I can't seem to phrase this correctly, but the exact deficiency pointed to the governing board's failure to, ensure medical staff operated under current signed bylaws, specifically to, completing medical charts. But then in the plan of correction, it asks how the same type of deficiency might affect similar areas. And how are we going to prevent, how was our plan of correction going to prevent a deficiency of a similar nature? And so what I see happening is, yes, we got dinged because the governing board failed to have, follow the bylaws when it came to charts. But then I think, well, is the governing board failing to ensure the medical staff operated in other areas as well? Are they, that's how I interpret how the plan of correction is written. It actually specifies that as one section Larry had to complete for the plan of correction.
Yeah, I didn't include
So,
the plan of correction, it was
you
too
know,
much paper.
I was gonna say, I'm looking for it, and
No, it's,
if,
really all the plan of correction says is,
cause it
you know,
says the
that
governing body.
we'll fix it by 6:30.
Yeah, it says the governing
That's all
body
they wanted.
failed to ensure medical staff operated under current signed bylaws, that the governing board failed to ensure an annual review was completed.
If you'll look at the,
And
the
I
other
had thought the
document.
annual review meant our policies and procedures, no?
no, there's more to it than that.
It is, so what are we talking about? And I wanna make sure we're doing it, so.
Well, we're gonna do it here in about 3 minutes,
Okay.
if we get to it. But going back to the survey, the monitoring tool that I've attached there, which was suggested by the, Critical Access Hospital Performance Improvement Network folks in Helena, that's really my work plan, the hospital's work plan, the governing, I'm reporting that to you as, to the governing board, that this is the way we are going to fix those things and follow through. You're accountable, for the plan of correction, because I'm reporting it to you that we're gonna do that, and you're gonna be asking me, I'm sure in the next few months, whether it's fixed or not, and the Medicare checks and the Medicaid checks are gonna continue to come. So I mean, this whole monitoring tool, this little 2-page thing, is really is kind of a summary, it really is a summary of how we're gonna fix this and how we're gonna do it going forward. And not just to fix it short term, but to fix it long term. Build it into Kirsten's, quality program, that's a requirement, of the plans of correction. And make sure that it, stays fixed, that we go through the bylaws and, the medical staff bylaws and the rules and regs in the second quarter every year. I mean, Mitzi is tasked in this monitoring tool, the executive assistant, with making sure that she tickle files, the CEO to start that process in, 2015, 2016, and 2017, so it stays fixed long term. The real reason that the surveyor got uptight, when she came to do the review, was that the bylaws and the rules and regs had not been updated since 2010. Mr. Cardy, I shouldn't use names, previous leadership of Mineral Community Hospital.
Leadership is questionable.
Well, the previous leadership at the facility did not follow through with the annual program reviews. Having said that, it is a very paper-intensive process, and it's not the first hospital I've seen that doesn't do it annually, and has been caught up in a survey like this. So, I mean, that's where we are, and we just need to work through it and get it back on track. Any other questions? Kirsten, anything more we need to say about the, about the survey itself, the plan of correction, the monitoring tool? I mean, that's what's happened so far. And one of the two major deficiencies in the survey were that caused us a lot of heartburn are these medical staff rules and regs and the bylaws. I mean, we've talked about that. We've got an approach on that. And the other big thing was this annual program review, which normally it's done outside the boardroom, but because it has to be done and reported to the board by 6:30, I just put it on the agenda. And,
yeah. I didn't know that was something that we needed to monitor.
Well,
to be honest,
it's actually the CEO's responsibility again to to keep track of that and report it up to. That's the way you are accountable for it. Is that the CEO has overall responsibility for the management of the facility, and that annual program review needs to be accomplished and reported to you each year and done. So
if we have a
efficiencies and.
And they won't be looking at it for the quality of the content or the quality of our performance. They'll just be looking at it that it contains the components that are required under the critical access hospital regulations. And Larry knows what those are, and he's writing them, and that should be good.
But from a board perspective, you should expect an annual report for your hospital probably at least 4 months after year end. I mean, there should be a timing issue of,
I've got a clean original. Are you okay with
I
signing?
don't know what Larry's writing up, but,
Okay.
you would suspect that the year ends,
Let's see when they do the.
things are done, cost report,
I'll
figures,
catch
volumes,
you
all
later.
that stuff is pulled together, and the
Right.
board is presented a report within
Sure.
a reasonable time.
And these policy books all need your signature too. I'll just catch up with you later.
Dr. Crawford, did you have a
We
comment?
need a stamp.
He needs to leave.
More, I have to go to the ER.
I think we'll go to the ER.
Yeah, go to the ER.
No, I think we got what we needed from that.
Well, as Kirsten said, we can buzz. Is it all right to go ahead with the annual program review thing then? And
Yes.
we need to do that today to
Yes.
to satisfy the surveyor.
If the rest of the board is okay with that,
Okay.
Yeah, and it'll come back and we'll get.
to skipping ahead to this since we were already in the middle of it.
Well, the first part is.
So everyone knows, that's under the new business, the Cobb Medical Record Survey and Plan of Correction. That's what we're at now. We'll come back.
You could look if you want. It's, public stuff.
the rest of the agenda
You
after we
probably-
get through this.
Bore you to tears. Well, no, actually, it's a kind of an interesting process, I guess. Yeah, the first part is just a description of the hospital, and, you know, we have 25 beds, 16 are non-skilled swings, sometimes called long-term care beds, but we don't like that term because the people who pay us don't like that term. They are non-skilled swings technically. And then we have the 11-unit assisted living facility. And I did, you know, I had a template from another facility that was set up as a, you know, rural health clinic, but, you know, I made it clear that here it's, you know, the health center is separate, it's a FQHC and it's separate, and between the two of us, we are the primary providers of healthcare in Mineral County. And then our mission and vision statements, you're familiar with those. I think it's important to revisit those. You know, it's part of the annual program review that you do that. We actually did that when I came. We made a few changes to the mission statement and stuff, and those are included.
I
and
think this is confusing to me, because this is in that policy that, as under Board of Directors and CEO, that first paragraph.
Well,
It's
what I was
confusing.
trying to do, it's my language, you know, I'm certain, you know, I'm just a,
Which one are you flagging?
Well, where it says both functioning as both legal representatives of, I'm confused with that wording.
well, there's both a 501, you know, I mean, you're really a 501c3, right? Plus,
And the hospital.
Yes,
plus
yes, function as both
That's
legal
what I was trying to
representatives
say.
of a Montana
Yeah,
nonprofit corporation. I just, the wording is, it's just confusing to me.
Can I clarify?
Yes, that would be great.
What
I mean,
would-
I
what would-
understand how we're structured, I understand,
Right,
um,
a board within a board, really.
yeah, really, it is, I just, the way it's worded was like, what?
What can we do to fix that right now?
Yeah, it makes sense to me, so go ahead, Amy, what do you think needs to change to?
I think it was, because we're talking about a hospital district and basically a hospital district and then there's the nonprofit corporation. The way it reads to me is that they're both representatives of the nonprofit corporation.
Oh, okay.
That's the way it read to
Well,
me, and I
wait.
thought,
And an elected hospital district board. Well, yeah, I don't know.
Okay, maybe you solve it this way. Functioning as both legal representatives of Montana 501c3 nonprofit corporation and as elected legal representatives
And
of the
as
health district board. Does that help you?
elected legal representatives,
Does that make more sense to you, Amy? I mean, I'm not troubled by the way it's worded, but maybe that makes it.
well, because you describe the board of directors, let's see. And I might just be hung up on
All right.
nitpicky stuff, I mean, it just didn't make a lot,
well,
was
it's important to be
confusing.
somewhat clear, you know.
All right, you can say, and those elected members as,
What is the both referred to? That's where I was hung up on both, are we
Well,
talking?
both legal representatives of the nonprofit and legal representatives of the health district board.
yeah, and I guess the distinction is the ones that are the representatives of the health district board are only those who are elected members, they're only
Yeah,
so
Trustees.
the trustees, so you do the board of directors and then you can do it as a separate sentence you want, if you want, and then say those elected district members also serve as legal representatives of
I think that would be better.
the district.
It just seems like we're cramming so many pronouns in there and it's just not clear which pronoun it's referring to. It just,
So I'll, well, maybe you and I can work on
Yeah.
the wording before we, you know, publish
Anyway,
the document,
yeah.
you know, and stuff.
cause this is the exact same wording that was in the policy that.
Right, I
The
took
first
it
reading of the
out
policy,
of there.
exactly.
I drafted it, but, you know, I put it in both things. It was suggested do that so that the accountabilities were clearer to the surveyors,
Sure.
In the way we operate. Well, and then, then you've got the, the org chart. That's all just kind of introductory stuff. Also, the hospital did do a community health services development assessment last year. Kirsten was very involved with that. Kind of informed me today, she was kind of the solo representative in most of those groups, but that's a really important process, and it does identify and gives you data, solid data on services and programs and needs, and so I recognize that in a paragraph there. Interesting, that the top 3 health concerns are there, listed there, and services that are missing, are there, and some ways to improve, which we talk about all the time in terms of quality, and more providers, and more services, more health education services. If anybody wants the gory details of the full assessment, I have that. I didn't even bring it down. I think it's upstairs, but it is an interesting document if you want to plow through the whole thing. It's based on a survey and focus groups done by Natalie Claiborne and MSU Bozeman with the Office of Rural Health. She does those all over the state. They're well done. We do need to list who needs to sign off, and that's listed there. Those folks that I talked about earlier. Then comes the policies, and they're all sitting here. There are 11 policy books. There are more policy books than just the 11 we have here. These are just the patient care policy books. The others do not need to be reviewed every year. They
Well,
should
and
be
we were
reviewed.
this came up a few months ago, and at that point, none of the department heads or anything had been through them at all, and I said, no, the board won't do it until they've been through them, so I
They've been through them now.
Yeah, so
Yeah.
we were just waiting for that to be done.
Yeah,
Before we
and
sign.
Mitzi, we set up appointments, Mitzi set up appointments for me. I met with every department head listed there, and they've all signed off, and maybe at this part of the annual program review, if you're comfortable, we could get the board to sign off as well. Unless you have questions about the process here. I did put a few words in there about, we do have a rather expensive, actually, electronic program that Mitzi got last fall, right after I came last
We
fall.
had talked about digitizing them
Yeah.
so that we could
Exactly.
access them.
So you don't, yeah. You don't
Cause it
have
was
the paper.
about a year ago, Gary and I came in and went through every single one of them. And all the new board members, that's one of the things on our training checklist is to go through the hospital's policy and procedures.
Well, I don't know if you need to have the whole board, but.
I don't think we need the whole board.
No, I think at not all, the intent was not to have to do it every board member all the time. It was at every board member should at least have gone through it once.
Oh, well, you could
That was
ask.
the intent, just to
maybe
go
you could
through it
have-
once, so there's some
This
familiarity
procedure
with
should
it.
actually go outside the full board meeting. It shouldn't take this kind of time,
Yeah.
and you could rotate around, who does the annual program review.
Yes, and
That would
we've
be
done
a
we've
good
done that
thing.
too, and we've split them up too, where, we've split them up too, where.
And
board
actually,
members took
the
pieces of it.
purpose of the sign off is not to, in my case as well, to me, it's not to plow through all of the policies. That's what we pay, strong clinical people, supervisors for, is to
Well,
make
and
sure
when there
the
are
books
changes, the board has to approve the policy changes anyway, so we should be seeing those as they come through. Correct? No?
Yeah, that's my point here, and that's coming
Yeah.
up here, is if there's anything substantial or significant that differs
from what we've.
That's new,
we've
from what
reviewed
we've
before.
signed off on, that should come to the attention of the board. You know, if it's significant, it's not like wordsmithing, it's something that's substantial.
Yeah, as a practical matter, it's pretty burdensome.
Yeah, but if it is substantial, we need to know about it.
Oh, yeah, absolutely. If there's a new program or something, or something like that, sure, yeah, absolutely. Most frankly, most of them don't change much. I mean,
That's true.
we did, this year, the one change has been in surgery. I mean, Kirsten's
There were a
surgery.
tremendous amount of changes in
Right.
surgery and updates.
Right. That's the one area we've seen change. Of course, that didn't occur in 2013, that's actually occurred in 2000. I talk about it later in the recommendations and the assessment part of the annual program review here, but, Tom Olding is probably a good example. I mean, he makes changes all the time. I mean, you'd be in the hospital, every week if you were approving all of the changes that he makes to his program manual, his policy manual. Frankly, I view most of these things as procedures anyway. I don't think they're policies much anyway. But for some reason, the surveyors call it, a policy manual. And you have to go through this annual program and you do that. Well, I don't know how you want to handle it. If you have further questions or you want to talk about specific policies, but if you dig into the nitty-gritties at this point, we will be here, as Carol said, till 7 tonight.
No, I'm okay with it.
Midnight,
Well, I don't know.
Well, and how much of it do we as a board actually have the expertise to judge?
Say, CEO, on clinical policy.
Right.
I guess
Well,
my
and that's
question is, have Laurel and Dr. Packard reviewed all the clinical
That was-
policies?
No. He just said, though, when he walked out, that he would sign off on it. That's his decision, I guess, medical staff's decision. Well, he said he would, I don't know that he said Laurel would.
So which ones do we have? Is this, are there more of these? Are
No,
these all of the ones that?
This is all of them,
Okay.
I think. Oh, Mitzi brought them down, there's 11.
Is that all of them?
Right.
I mean, it's as a board, it's our responsibility to see that we have an infection control policy. But we sure don't have the expertise to judge
That's the
what's
way
an
I look at it.
appropriate infection control policy. It's not in my training.
Any of the clinical policies.
Yeah.
Well, except here.
I would say the governing board would just ask, do you have a registered nurse in charge of your infection control policy? Is she keeping herself updated on the current practice? Has she reviewed and updated policies?
Oh.
Nancy, have you
Why?
had time to make all my edits?
No, because the share drive was just back
This-
last week,
Okay.
and the share drive was gone.
So,
I view it as a rather dynamic process.
I do,
Yeah.
but
It just goes,
I'm
it
looking
goes
at
on all
this,
the time.
if
And
you look at
Missy's kind of the
look at who has signed off on them. But you said Dr. Packard has agreed to do that.
Well, he said that
He
when he
did say
left.
he's agreed to do that. Just on this one, so you have department supervisor has signed it. CEO, board member, it doesn't even have to be the chair, it could be any board member. Director of Nursing Services, mid-level practitioner, so.
The lab one is probably the only exception. The pathologist, the consulting pathologist, she was actually here a couple days ago, and she signs that as well, because she's responsible for the clinical supervision of the lab techs.
So have the staff signed off on these?
Yeah, every one of the departments.
If they have, then I don't have a problem signing on.
I haven't in 2014.
Pardon?
Not the individual policies.
Right.
They're required to do it once a year, and I reviewed all my policies in May sometime of 2013. I've updated some since, but the edits have not been made on my 2013 requests for revisions on all of them.
The surveyors typically will accept the handwriting.
Yeah,
I've gone through resurveys 2 or 3 times when they don't care if it's
They're not
all
pretty, but
fancy, and as long as it's initialed by the department head, they accept that. They'll accept it.
So what we need, the board would need to officially approve signing off on the policies and procedures, right? As well as the annual program review, which is what we're
Yes.
going through right now.
Right, that's correct.
Okay.
There's a little bit more to it. This is just part of it. The policy review is part of it.
Okay.
There's a couple more things we need to talk about. And Kirsten, I need her help with some with the clinical stuff here. This is more her thing. You know, some of it. She understands how the systems work much better than I do. Do you want to go ahead
So,
with
do we-
this, or?
Well, yeah, I think we just need to move forward unless
I'll
there's some
move.
problems or
Yeah.
some objections.
I'll move the board, sign the policies for the year.
Thank you, John.
And I had a,
We have a motion.
oh no, I don't need it.
Second.
Do you second that, Gary? Is there any further discussion about the policies and procedures? All in favor of signing off on the,
The only question I
Go ahead.
have is on page 13, at the bottom of the page, under procedure. I keep bringing this up again, kind of
Where are you looking
a
at?
nagging thought.
On the annual program review thing?
Yes, under
Okay, page 13.
healthcare policy review, page 13.
oh, this isn't an official policy yet.
Okay,
That would be included.
all right.
Oh,
That wouldn't
So-
be included in
So
this.
we're not under new business in this
No,
area?
no, we're not doing that.
Then
We're
we-
just doing these,
Okay, when we get to this
Already-
area, I have a comment.
okay.
sure.
So yeah, this is just for the already established policies and procedures.
All right.
So basically, we're trusting the people that understand what's in these manuals to review them and sign off on them. And
It
always,
has been.
if they have reviewed them and signed off on them, then we're just saying, we trust them that they're correct, adequate, whatever.
Well, and you understand that the system is working.
Yeah,
Yeah.
the policies are
That
there,
there is a
they're in
policy
place.
there.
Yeah.
Yeah, I mean, we can't, again, we are not charged with having the expertise to evaluate the
I certainly
nitty-gritty
hope
of the imaging policies. That's, again, that's a degree of its
Yeah.
own.
Okay.
Yeah, good question. Okay, if there's no further discussion, all in favor of signing off on the current policy, procedures and policies?
Aye.
Any opposed? Okay.
Oh,
Let's
thank you.
move forward with that.
Okay, so,
So let's move forward with, the review.
next part of it is the utilization of services. As part of the annual program review, we need to look at the volume and the patients, the patients served, the volume of the service and the patients served. And Kirsten and I talked about this. We really only have 2 basic lines of service here, right? Is that correct, Kirsten?
Yeah.
I mean, we have the emergency department and we have med surg, right? You know, the acute care floor. Those are the 2 service lines that we're gonna look at utilization for. Is that correct?
Well, those are the only 2 departments that the medical staff acknowledges.
Right, that are,
All right, I'm
So,
confused.
the annual review covers the whole facility.
pardon?
The annual review should be for the hospital, and not just,
Right,
medical
not just the
staff.
medical staff, yeah, correct.
should review volumes of all.
And if you look at the, well, if we go to the dashboard report, Kirsten presents to the board periodically, usually monthly, if we don't lose our shared drives, and some of our issues like we've had lately, but, you know, we have, you know, in 2013, this is fiscal year 2013, but we have, you know, acute patient days, which gives you an indication of inpatient volume there. The benchmark is 31 a month, and so we've been under that benchmark, which shows that we're not utilizing our beds, at least to our benchmark, you know. The benchmarks are based on historical numbers anyway. I mean, they're really tied back to the budget, so they're they're based on the previous year, and so that means that our trend in inpatient days has been moving down. We do have a data gap. We don't quite understand that. We'll have to go back and find the information from Cliff's reports, I think, on the number of individual acute patients admitted. The short piece of trend that we have there, about 6-7 months, it looks like we're underneath every month, well, except that a couple of months we're above, I guess. But,
Larry, that data that's missing on number of acute patients admitted, that was not a volume measure that the board had requested until January of 2013.
Oh, okay, so you just weren't even reporting it up.
Right.
Oh, okay, but the point here is that that we're looking at the utilization of these services, also the two major services, the ED and Med-Surg, and we just have to document in the annual program that we've looked at that, and we're looking at the trends. They're slightly down, slightly up, whatever, and we'll make some conclusions about that stuff at the end in terms of the assessment. So we don't have to do anything formal with that or accept it, other than I have to report this stuff to you in the annual program review. The financial indicators and risk management indicators.
Are we still on the dashboard?
Yeah, well, I flipped back to it for a second there, but those areas are not really, well, they're somewhat relevant, I guess, some of the risk management indicators, but the main thing here are the volume or the utilization indicators. That's what's required that we look at in the annual program review. So this is my, Kirsten and my kind of quick and dirty way of us doing that. If we had more time, we'd probably total some of these numbers and talk about the trends from year to year and do it a little bit more professionally. But because we really need to get this in place by 6:30, we're presenting it to you this way. Okay, so flipping to the peer review, and here's where I really need Kirsten's assistance. Maybe I'll just come around and let her take over with the peer review stuff and explain that process and how it works, and the data, hopefully from her reports and her information, can kind of satisfy the surveyor.
I think what the governing board expects from me as the Quality Improvement Committee coordinator is that I present to you on a regular basis how we're doing and how we're measuring whether or not we're meeting the 4 quality improvement goals. And so what I present in the Quality Improvement Annual Program Evaluation, which you haven't seen for 2013 yet, we had 2012's. Larry's referring to page 10 in your packet. The top of the page, it says attachment B, page 1 of 2, and so we're looking at page 10 and 11. So Larry's going to take information from my quality improvement annual program review and incorporate that into the overall hospital annual review. And so if you read through that, I've stated what our 4 goals are in my report. The beginning on the first page, it says goal number 1, evaluate the quality and appropriateness of diagnosis, treatment, and treatment outcomes. And then for all of that first paragraph, the information that I'm presenting there is to show the governing board what our hospital did during 2013 to evaluate those things.
Is this calendar year?
It is calendar year for quality. So have you folks had time to read this yet? It might make sense for you to just take a few minutes and read it. And you'll see there are some gaps in it. That's due in part to, it was this morning when Larry came to me at 9:30 and was working on this and needed this information. And unfortunately, a couple of those reports, like the Utilization Review Committee report and the Infection Control Committee reports, were two of the reports that were lost with our data problem. We recovered the Utilization Review report, but it was too late to get to Larry in time for this meeting. The Infection Control Committee report, we still haven't found.
All those files were restored, but some of
Our
them,
infection control nurse, Nancy Myers, isn't here today, so if she has it, I'll get it from her, and I do have the capability of rewriting it, we do have all the data.
yeah, if you
It's a
flip
matter
back,
of about an hour.
if you flip back to page 5, I've included from Kirsten's annual quality review, program review, some information about peer review and how that process works here. We have an ongoing peer review process. And we do meet the minimum standards. In fact, this is where I need some help, I guess, from Kirsten as to how that process works in terms of peer review. But a minimum of all, a minimum 10% of all active and closed charts, are reviewed for physicians and physician assistants, and we don't have any nurse practitioners. It's kind of odd. Nurse practitioners, we didn't employ any, or no nurse practitioners provided any service at the hospital in 2013. They require a 25% chart review. And so the peer review process that we have ongoing meets those minimum standards, and I would expect, Kirsten, correct me here, fill in for me, you more than meet that. I mean, you review most charts, don't you, on inpatients, in terms of peer review?
I thought in 2013, we did a pretty good job in meeting the regulation for external peer review. We're required to send for external peer review 10% of every provider's cases with a minimum of 2. So we would send for every provider who works for us a patient's medical record, 2 for Frank Townsley, 2 for Dr. Packard, and so on, out to have them externally reviewed, and then they would come back. At the time it would have been Dr. Lovell, sat down with those providers, reviewed the reports, and then put together some type of plan for corrective measures if needed. And in 2013, I think we did a pretty good job of that. We, at least the medical records department was getting those records sent out, and they were coming back in, and Dr. Lovell was sitting down and doing all that review. We were also doing what I thought was a pretty outstanding job reviewing internally, which isn't required, but that was almost better. You can see we did 47 cases.
Yeah.
With the internal peer review process. Now, unfortunately, it's different in 2014, but that we won't be addressing that here.
And, Kirsten talked about the infection control, that report. We don't have that. I don't have that. It's one of those reports that is hung up in the shared file drive, or we haven't found it yet. We will get a hold of that and put it as part of this, but
I'll tell you what you'll read about, though, in that report.
well, right.
Nancy Myers will tell you what the Infection Control Committee's goals were for the year, and she'll tell you what we were able to accomplish. You're going to read things like one of the goals was for the Infection Control Committee to meet 4 times during the year, and she'll probably be reporting that they met 2 times during the year. She'll talk about how well the different departments were represented. She'll talk about their goal was to complete 1 quality improvement project in 2013. And she'll say that we were not able to meet that goal, and she'll give the reasons for that. She'll also present to you, and I'm going to back up and say, not only will she present this to you through the annual program review, she presents this to the medical staff on a quarterly basis. And in my eyes, that's what the governing board is counting on. They're counting on infection control to present this to the group of people who are concerned about the quality of appropriateness in diagnosis, nosocomial infections and that type of thing. So every quarter Nancy will report to the medical staff.
You should probably
the number of
explain what
cases.
explain what nosocomial is.
Oh, I know what it is, sorry.
Oh, okay,
Well,
well, some don't.
not all of us do.
Yeah. I think,
I would
Sorry,
be one
I'm
of
sorry.
those.
Sorry.
yeah, just tell them.
Infections that were caused by something we did in the hospital.
Oh.
Right. Sometimes they're called,
So she'll
As
report,
opposed to a community acquired.
Right.
right.
yeah. She'll report those numbers to the medical staff after she reports them to her infection control committee. So that's kind of your first line of defense in recognizing there's a problem. Then medical staff will look at those numbers, and then ultimately the governing board. But I think you are counting on the medical staff to identify bad trends and jump on them.
Yeah.
So you'll be reviewing, she'll be reading that in her infection control report too. And that's pretty much it for infection control.
Yeah, this whole piece, this whole section, really is for the purpose that the board understands that we have a process, we have a policy in place, you know, to do the peer reviews, you know, we're doing it on an ongoing basis, and we're at least checking 10% of the physician and PA charts and 25% of the nurse practitioner charts if we had any nurse practitioners working for us. And for some odd reason, they kind of throw in this requirement that you have to have an ongoing review of nosocomial infections and medication therapy, the resulting medication therapy. So,
Well,
you know, the
it's,
purpose of all this discussion is just to
because
satisfy
it's
you that
in
we're
larger
doing
hospitals,
it.
it's a real problem.
Oh, absolutely, absolutely. Yeah. Sometimes they're called hospital-acquired infections.
Like a staff. Sometimes
Or
hospitals.
MRSA.
MRSA,
MRSA.
thanks to St. Pat's Surgery Center.
Or pneumonias, there's different pneumonias too that are that way. The clinical outcomes committee, it says that the report, the data was not, let's see, you did not report the data publicly via the CMS Hospital Compare website.
Right.
So, that's not something that is required? Or is that just something
It's hard.
Do we normally do that?
Hospitals to do that.
It's something that we've been talking about for a couple of years now. I remember conversations with the governing board
Yeah.
that the reason that we're opting not to report yet is we want an active program and we want numbers that we can bring, you know?
Yeah.
I remember having a conversation with Lori about it, and I think she was present for when we were reviewing our chest pain protocol numbers and how we need to get some active involvement before we start reporting it publicly.
A lot of the hospital compare things too are,
Are you comparing apples and oranges?
well, the problem with small numbers, you know,
It's not statistically.
one case, you know, in a hospital this size, you don't have any volume anyway. I mean, it's,
Right.
Yeah.
it's very misleading. A lot of small hospitals just intentionally won't even do it, you know.
It's more luck of the draw than it is a
It makes you look
reflection of how
bad
you're
when you
doing things.
actually do it. You know, you have one death out of,
Yeah, we had 3 patients and 1 death, it doesn't look good.
Right, right, but when you have a total of 4 patients,
Yeah.
it's pure luck of the draw.
Exactly.
Um,
It's tough.
well, can we move on to the assessment piece? That's the last piece, is that correct? You know, I just threw some kind of conclusions in there. They need to be data-based, and I tied those, just some kind of conclusions, I guess, about the process with the annual program review that, I would hope that you would agree that the utilization of the emergency department and the acute care services, the med-surg services, was appropriate with those review functions in place that we've been talking about, and the volumes that and the utilization that we talked about. Same with the patient care policies. We today went through those and explained the process that we're going through. So, hopefully you would be comfortable saying that those policies are being reviewed and updated and followed, at least annually. sure we do it annually. And then I did comment on surgery. I kind of talked about it before, but there was a very specific comment in the Community Health Services assessment, development assessment that talks about the community would really like to see surgery services reestablished here. I mean, that came out in May of 2013, and we did follow up on that. We formed the cost-benefit analysis. John Updike did that in late December there, right? Well, even before that, and he'd actually worked with Cliff and performed that cost-benefit analysis, and that was approved by the board, and we did bring in a part-time general surgeon, Dr. Gardner, so we don't have to report those volumes and utilizations this year because we didn't crank that up until 2014, so we're talking about 2013, so in the future we'll keep you posted. I mean, that's one of the things that the annual program review is to follow up on any new lines of service, any new surgery services, any new patient care services, and look at the trends in utilization and then move on from there, and keep the board involved with that process. So, hopefully with that, I would ask that you make a motion to accept and approve the annual program review, and we'll be done with it until the surveyor comes back.
I'll make that motion.
Thank you, John. I'll second it. Thank you, Carol. Any further questions or discussions? All in favor of approving the annual program review?
Aye.
Any opposed? Okay, motion carries.
Well, thanks for your time for all that stuff. Well, we still have, I guess, those two policies, right?
Well. Yeah. Which is gone out. So, okay, so we did the annual. Okay, the administrative, this is our first reading. I don't think we approved those on our first reading.
The last time we had a policy, we had included it in the packet, and having a packet prior to the meeting
We had a chance to review it.
right, and so it was able to be voted on.
Well, I would have the same comment that I had on the annual program review about the confusing wording.
Yeah, that wording.
Under overview for the board of directors and CEO authority and responsibilities. Gary, you had some comments about.
Well, under the healthcare policy review, is that the subject we're on right now?
Yes.
Okay. Under the procedure, and I'm assuming that this, what's the landing spot as far as the board is concerned for this document? In other words, is the board responsible for seeing or approving this procedure policy, this review? Is the board responsible here?
Yes.
Okay.
Yeah.
Well, it says the CEO shall report the policy review to the board
Right.
each year.
And so it kind of gets back to that nagging question about if there's some, I understand we're not all clinicians and we're not all experts in our department, but if there's something that comes up that the board needs to know about that would impact patient care in some way that would be significant, that the board would be notified that this is a change that could be substantial.
Yeah.
We could add that line.
That's
Yes.
what I'd like to have in there. Yeah,
Good point.
sure. That's my, yeah.
That's a good point.
It's reported to the board.
Yes.
Would that be a number 4 on the procedure?
Sure.
Yeah. 4 or 5.
Well, with those two changes then, I mean, it sounds like I have work to do to clarify
Just the
that
description.
other thing.
Yeah, and the overview.
Yeah, the overview and on the other policy, and And then this, impacting of patient care is reported back to the board, yeah, absolutely, anything that would do that, significant impact. If you could maybe approve them contingent on.
With those changes.
With those changes,
Yeah.
and I'll make sure those get back to you right away.
Great.
We'll have Gary review it and Amy review it before the signatures are applied, so you're comfortable.
Works for me. With those conditions, I'll move that we approve.
Okay,
Second.
thank you, Gary. You have a second. Any questions, comments? All in favor of approval of the Board of Directors and CEO Authority and Responsibilities Policy and the Healthcare Policy Review contingent, according to the motion. All in favor?
Aye.
Any opposed? Is Tanya still there?
Yeah, you didn't hear me?
No, I didn't hear you. I just wanted to make sure. If you do have to leave, just make sure you let us know.
Okay.
Okay.
Yeah, probably what was happening is you said yes at the same time somebody else said yes, so it was the non-duplex nature of a speakerphone.
Yeah, goes one direction. Okay, so let's go back up to our next gen report. And then we will follow our agenda at that point.
Sorry.
Now, can you back up a little bit? Deb, are you gonna do that?
Yeah,
Mary?
I guess. Okay, so next gen, we continue to, work diligently through things. We are fairly rapidly moving out of a paper world into a clinical world and getting more and more documentation into the system, which again has been, a great process by the clinical staff to move, going from completely paper into an electronic world. Things are way different in your everyday functions, and so getting people used to doing those things. Like Dr. Packer said, even the bylaws and some of that stuff is so different with what you do in electronic health record versus paper, that some of those things are gonna have to change just to reflect that we're using electronic health record now. But we, are billing, have been billing now for, pretty close to a month on some claims. The billing office, which pretty much consists of one other gal and myself, have gone through every claim through May 9th. We have some that we have chose not to finalize and bill out the door because we need to go back and look at documentation. We've found some claims that have the same charge 3 times, and we're backing those charges out. We have some charges that aren't in there at all, and we're putting those in. But the pharmacy department is reviewing their charges every day of what was administered the day before. And if there's errors, they're getting this to us so we can get it in the system. Lab and X-ray are doing the same thing. Supplies, so the departments are all looking at what they did from yesterday and making sure that we're capturing charges, which wasn't a process that was happening in the paper world. So hopefully we will find some revenue in some of that, just in lost charges. We currently have about $1 million sitting in unbilled. Not all the charges are in.
Round numbers, you did bill about $500,000, right?
Yes.
You know,
Yeah. So we have right now about about $1 million sitting in unbilled charges. If you think about the revenue that we get, if we just round it off and say, we get $500,000 a month in revenue, and we've had since the middle of March, all of April, all of May, and a little over half of June, we really have almost 4 months worth of revenue, so there's $2 million out there that, I would say probably close to 500,000 of that we haven't put into the system yet, because we're still reviewing charts. We've billed out, probably closer to 600,000 or 700,000 now since we visited a few days ago.
right, yeah, you guys have been working.
We submitted,
in the last 2 days, we've submitted $100,000 in claims. Yesterday's claims went through the clearinghouse and to the payers without errors, 100% clean claims, so that's good. So we continue to watch all those. At the same time, when we switched next gen, we also had to switch clearinghouses, who is the gatekeeper for us. We send our claims to a clearinghouse. They do a whole bunch of editing, making sure that the claim is completed correctly before it goes to the insurance company. And that's the electronic version of that, goes through the clearinghouse to get there. So so we've not only had to train on next gen, we've had to train on a clearinghouse, and we're getting through that as well. So
What's
like
the
I said-
typical amount of errors that you would get running it through a clearinghouse? You said there was no errors this time, but what have you seen prior to that?
Well, you know, in a new system, you're gonna have errors just connecting things up, but, you know, on a day-to-day basis, you're gonna get, you wanna have less than 2% errors as you're sending things through. That means you're capturing correct ID numbers on the front, that, you know, that you're verifying that they truly have Blue Cross before you send it in, because an error can be as simple as, we can't find this person in our system, and it rejects back. So if we're getting 100%.
What kind of percentages were you getting prior to next gen?
In paper?
Yeah.
I don't know.
You don't know.
I don't know, of the old system.
So are we catching up?
Are we catching up? Yes, our goal this week was to try and get all of May into the system. We're not gonna quite get there. We probably get through probably about the 20th of May. But we're also currently doing the claims that are 5 days out. So we started the first part of this week going 5 days back, which is what our goal is, to get a bill out the door in 5 days. And so as of today, 5 days back, we're billing those claims. We're making sure the charges are in there, and we're billing those claims. And then as we get those looked at and corrected every day, then we're going back to May and catching up on those older claims. So we're doing current claims, plus we're doing the older
So we're now
claims.
doing current plus closing the gap.
Yes.
Yeah, that's what
Yes.
I was gonna say, what's our current accounts receivable look at? What's our current number on our accounts receivable?
we don't have one.
I couldn't tell you what it is.
Cause we haven't been able to close the months yet.
Right.
Yeah. You know, they're gonna be high. If I had to guess, I would say our AR days right now are probably close to 120 days. You know, maybe even a little higher. But we went 45 to 60 days without sending claims out the door. We received a check today from Medicare for $20,000. We've gotten probably close to what, 70,000-80,000 out of the Medicare system so far, off the next gen claims. Medicaid. Yeah, we're receiving Medicaid dollars. New West, who has also gone through a conversion, their conversion started in November. They have not paid claims up until April.
New West is.
New West Medicare.
So
A Medicare Advantage program.
My insurance.
Yours?
Yeah.
So they went through a conversion that started in November. They've just recently started paying claims. And our claims that are coming off of next gen are going through New West and being paid almost within a 7 to 10 day time period. So they've got their system. In fact, I called and asked for a lump sum payment from them about a month ago. So we did receive a lump sum. They've cleaned that up and got it out. So the money's starting to roll back in again. You know, obviously, like Cliff shares with me every day, he'd like it to happen faster, which I agree with.
So we do.
I
At
tell
least.
Stacy that I'm just controlling how the money's coming in, because she spends it too fast, but that's not a true thing either, so.
Yeah,
Anyway.
we definitely need to mention that, you know, our payables, you know, Stacy can address that, but we're, probably 2.5, 3 months, getting pretty close to 3 months.
Yeah, we're almost close to 3 now.
3, yeah. I mean, we've got a big chunk of payables sitting out there that we need this cash, you know, to get in here, so we can clean that up and move forward.
So, things are going out.
But it is
Things are
coming
looking
around.
good. The clinical people are doing, you know, every day there's improvement. We're getting down to a point now where I can't just look through paper any longer, so I'm overwhelming Kirsten with, well, maybe not overwhelming, but, she's getting my emails every day saying, you know, I don't see this, I don't see that, and me being a non-clinical person, asking stupid questions, she probably gets a little annoyed, but she's auditing charts as well and going through them and making sure that, things are in there, and then also being able to go back to her staff. Kirsten, do you have any?
Yeah, I'd say, Deb, I don't feel annoyed at all. I'm just so impressed with the business office's tenacity at making sure that the bills are correct. Yes, she'll send me something like, we have this patient who was into the ED, and the diagnosis was drain and abscess, yet there were no supplies recorded. And so I go in and look at it, and, you know, there were no supplies used, but she's in there, she's checking all these details to make sure that we're getting it
Well, good.
accurate.
Yeah, good.
At what point, cause right now it seems like everything's having to be back-checked and rechecked and, you know, it's really labor intensive. It sounds like from what we're doing right now, at what point are we gonna be able to say, okay, we have faith in the system that it's gonna kick the right things out?
Well, I think, that,
Or is
you
it-
know, every
You're
day
there.
it's the clinical people getting more used to doing what they're doing, which enters the charges. From a billing office perspective, this is never gonna go away for us.
Okay, that's my
Previous-
question, is
previous
it
to
always
this-
gonna be so labor intensive? I mean.
Less so.
A little less, but previously, we were going through every chart and entering every charge. So now we've become not data entry.
But double checking.
We are auditors now. And so going back and looking and making sure that
That's a good
things are
point.
in the system is really what the billing office staff now has to switch from being keyers to auditors, which is a whole new process for them as well.
And that's part of the reason she jumped ahead into June to do current stuff, so that they could educate everybody as it happens. You know, say the supplies are missing, then they can let whoever was responsible for that know that this is what you have to do. So it's gonna get, it is gonna get better.
And the
I
clinical,
think it already has,
Yeah.
and, you know, I would
Yeah.
use, the thing that really caught my attention, and I told Kirsten this the other day, that, she was working the floor with one of our providers who shall remain nameless, who is not a very good documenter in the past, but, you know, she was, I think uses the electric cattle prod and gets this particular person to, to document properly and appropriately, and the patient in the ER, unlike most patients, we rarely see this, but that person wanted to, wanted to bill and wanted to pay it cash on the spot. So, Deb, she, gets in the system and looks it up, and, expecting that, she's gonna have to scramble around and do all these things, to get missing charges and stuff in there, to get this thing fixed. But lo and behold, everybody had done the right thing, right? I mean, that's the way you reported it back to us, that,
so if they're documenting in real time, by the time
Yeah.
the patient is ready to discharge, the bill's ready to go.
It should be.
I mean, it had the supplies on
exception
there,
of
it had
coding.
it had the labs on there, it had it had all of the stuff on there. There was a slight delay. I think he had to come back in the next day or something and, pay the bill, but, he was able to do that. I mean,